real scope of practice that we're doing, and and to carry a checklist. All right. I mean, there's nothing wrong with having a checklist and having it in your pocket or on your clipboard or wherever you want to keep it. I mean, there's no problem with that. There's nothing that says that you have to memorize these all these different approaches for different problems off the top of your head. I mean, shoot, I'd rather have somebody we always called it our pocket brain, right? I mean, your quick referrals that you look at when you have different types of patients, to make sure that you do everything that you should be doing, and as a reminder. I mean, there's no problem or shame in that at all. It's much better to do all the things you're supposed to do, regardless of how you have to remind yourself to do them, than to come back and realize 2 hours later the outside hospital is calling us going, oh, by the way, that glucose on that 7-year-old was 25. We just now got the results back, and here we've been carting the patient for an hour and a half. Okay. So that's the general approach for a patient with change in mental status, and it can be anything. All right. I mean, the reason it's nice and vague, change in mental status, is because this is the approach you need to use regardless of necessarily of what the history is. Okay. If someone, say the parents were in the front yard talking to their neighbors, for 20 minutes, and they walk back in, and they found their 2-year-old, okay, on the floor in the living room, and they have no idea what happened. All right, you approach it the same way. If someone found a 13-year-old, okay, in the mall, and they didn't know him, they were a complete stranger, and they call 911, and all the history is this kid was found, on the floor in the mall. You'd approach it the same way because you have no idea what's going on. Somebody brings in a 6-month-old with a seizure, okay? It doesn't really, necessarily matter if the conditions of what happened are known or not. You start the same rundown, the same workup in the same manner. I will warn you, especially when it comes to this particular problem, take the history with a grain of salt, all right? We try to do things, certain things in medicine in a certain approach for a reason, because we know we can get fooled. We know that we can listen to one bit of history and hang on that, when in reality it's a red herring. It has nothing to do with what's really going on with the patient, okay? And we know that can happen. Again, if you're not finding a definitive answer, then you keep working your way down the list, and that way, hopefully, all the bases are covered, and we find out the real problem, okay? So always remember that you're going to be, working with a team. When you walk in, decide who's going to be who, okay? I'm going to be the primary ABC manager. You're going to be the primary investigator, or whatever you want to call it, so that all these things are done. Obviously, if you have an airway issue, it takes 2 people to manage that, so that's where your focus goes first. But as soon as you have that addressed and taken care of, then you can kind of split off, and one become the primary patient, one become the detective, or whatever you want to call it, to make sure that the workup's been done. Okay? Can I use your name? Okay, Danielle asked a couple of good questions. She said, she goes, well, I got it that you want us to check the calcium, mag, and phosphorus, but what exactly do they do? And I didn't mean to cut that short. It's just that this whole going through the differential is a much longer process than that's where this workup comes from. All right, but you can get seizures with hypocalcemia, hypomagnesemia, or hypophosphatemia. And again, unless you are looking for that, there's nothing about the patient, okay, that's necessarily on physical exam. It's not going to tell you, unless, of course, they have tetany or something. But usually by then, that part's gone. Not necessarily, but many times those symptoms would have occurred before you encounter the patient necessarily. But so you can have seizures from abnormalities in those electrolytes. The other thing she asked about, which I actually left out of this, is cardiac or arrhythmias. Okay, so that's on part of the differential too. So you should look at that. Again, the problem with that is potentially that could have also been missed. It's kind of like a seizure. It could have happened when nobody was there, when nobody saw, or even if they did, they might not have realized that, what that was, because an arrhythmia is not something that as an external person you see. But we certainly need to look at an EKG, although knowing that just because it's normal sinus now, doesn't mean that they didn't flip into V-tach, and that's why they passed out, to start with, or they had, some other arrhythmia at that point in time. So the evidence may not be left, but certainly is appropriate for you to look at it, and, because it may be there, okay? Anything else? Okay, good. Thank you.